Hello. Right, good afternoon. Thank you very much for coming this afternoon to the glaucoma session. We've got an exciting lineup of talkers arranged for you today. I hope you all agree we've had an excellent conference so far. This is the post-lunch slot, so I don't mind if it's a bit of a slow start, but thank you for the ones who have made it for the beginning of the course. Glaucoma itself is a very important disease to recognize and to treat appropriately. Unlike other conditions, it's irreversible. So once the damage is done, there's no way back. Often it's under-recognized, or in some patients it can be almost over-recognized and over-treated. So there's often a difficult diagnostic dilemma to make with these patients. So we've got some good speakers today arranged for you. So we will start with Dr. Walid Tantawi, who's going to speak to us today on glaucoma topics. Thank you very much.
Good afternoon, everybody, and Assalamu alaikum. Can I have my slides, please? My topic today is about surgical advances in glaucoma management. I have no financial interest in any of the products in this presentation. Well, let's start with the saying that recently there are no new ideas in glaucoma. Let's see how many of you do not agree on this saying. If you do not agree on this saying, just hands up, please. Recently there are no new ideas in glaucoma. Just one, two, okay, three. Quite few. So most of you think there are new ideas in glaucoma. To answer this question, let me take you in a time machine through the evolution of glaucoma therapy. We are now in 1856 in Berlin University. Professor John Grafey invented the surgical iridectomy in 1856. And a few years later, pilocarpine was invented. And for almost 100 years, this was the only treatment for glaucoma. In 1969, trabeculectomy was invented. And a few years later, Molteno valve and timolol in 78. And then in the 90s, dorzolamide, brimonidine, and latanoprost. And since 1969 until today, almost 55 years, trabeculectomy is still the gold standard for glaucoma surgical treatment. However, it's far from perfect. Why? Trabeculectomy can be unsafe due to hypotony-related complications like maculopathy, kissing choroid, suprachoroidal hemorrhage, or bleb-related complications like cystic, thin-walled bleb, leaking bleb, large uncomfortable bleb, or blebitis and endophthalmitis. So what are the new surgical devices available in the market? Now, the ideas of all the surgical devices are micro-invasive glaucoma surgery. The primary cause of elevated intraocular pressure in primary open-angle glaucoma is abnormality in the trabecular meshwork, with up to 75% of resistance to outflow in the trabecular meshwork. The aim of MEGS is to bypass the trabecular meshwork by making a connection between the anterior chamber and the Schlemm's canal, or the anterior chamber and the subconjunctival space, just like the trabeculectomy, or directly to the suprachoroidal space. So a connection between the anterior chamber and the suprachoroidal space. A very short learning curve, only 4 to 5 cases, and cataract surgeons can take it on. The first one is the eye stent. The eye stent is the most famous now. It creates a patent bypass between the anterior chamber and the Schlemm's canal. This is the size of the eye stent compared to a penny. This is a gonio lens. Oops, sorry. So it's a L-shaped. This is the size of the eye stent compared to a penny. That's the injector of the eye stent, guided by the gonio lens. So this is the eye stent, and that's the injector. So basically, you go in the Schlemm's canal and inject the eye stent. You'll find some hyphema, then you adjust the eye stent. You go out with the injector, and this is how the eye stent works. So the aqueous will go from the ciliary bud to the anterior chamber through the eye stent and go to the canal and to the veins. The next one is the trabectome. It's clear incision, then injection of viscoelastic, then again guided by the gonio lens. You go in clear cornea with the trabectome. Then you'll ablate the trabecular meshwork. So something like a cautery. Ablate the trabecular meshwork. Now you have free connection between the anterior chamber and the canal. And that's the idea of the trabectome. The next one is excimer laser trabeculotomy. Again, you go with the probe of the laser in clear cornea until you reach the trabecular meshwork. That's the canal here, and that's the trabecular meshwork. And you start the laser. That's an opening. So that's the laser probe. That's the trabecular meshwork. And you ablate with laser. And that's the opening you have. And you do this several times beside each other. You have several openings in the trabecular meshwork. You repeat this several times. So you have several openings. And you bypass the resistance in the trabecular meshwork, which is the main problem in primary open-angle glaucoma. Next one is the Hydrus microstent, the intracanalicular scaffold. It's a stent that stretches the Schlemm's canal 4 to 5 times of its actual size. So basically, you inject these two stents, okay, one on this side and the other one on the other side in the canal, and then you'll have you'll search something like the viscocanalostomy, and you'll enlarge and stretch the canal. So all these previous ones, the 4 work on stretching or doing openings and work on doing a direct communication between the anterior chamber and the Schlemm's canal. The next one is the sclera bypass stent, the Aquasis. It's a gel stent that creates an outflow of aqueous from the AC into the subconjunctival space, something like the trabeculectomy. So basically, you inject the Aquasis from ab interno between the anterior chamber and the subconjunctival space. And the next one is the express shunt. The most important steps in implanting the express shunt is to identify the landmark where you will put the express shunt. So the incision should be made just anterior to the sclera spur and posterior aspect of the limbal blue zone. Can I have my video, please? So here, this is the landmark just anterior to the sclera spur. Can you play the video again, please? Here, this is the landmark. And the size of the flap is 4 by 4. Use a 27 or 25 hypodermic needle and insert the express device on its side, then you rotate it. Close the conjunctiva, just like the trabeculectomy. This is how it looks. So basically the aqueous will go and percolate through the express shunt. It didn't really help the problem of the bleb-related complications, but it prevents early postoperative hypotony. This was a big failure. It's the gold shunt, suprachoroidal bypass. It's a flat device that establishes a pathway between the anterior chamber and the suprachoroidal space. So basically, the aqueous will go through this gold shunt. And this is the suprachoroidal space. But it was a bad device, actually. And finally, the CyPass. It's a suprachoroidal stent. Something like the Aquicess, where you inject this stent directly to the suprachoroidal space. Well, what are the problems of the microinvasive glaucoma surgery? The canal surgery are limited by episcleral venous pressure because IOP cannot lower beyond 16 millimeter mercury. Scleral bypass is bleb forming, so you still have the same risk of subconjunctival fibrosis and failure. Suprachoroidal shunt is prone to fibrosis, and still the cost implication suitability for developing world is still a question. So now I believe that the best is yet to come, because I don't think that trabeculectomy will last long, and I hope by the end of this presentation that you agree with me that the best is yet to come. Thank you very much.
So thank you very much for that excellent talk about MIGS, so microinvasive glaucoma surgery. The key thing with MIGS is that it's largely conjunctival sparing. So the two most popular methods are iStent at the moment and trabectome. And by and large, they spare the conjunctiva. So if you want, you can still do conventional glaucoma surgery after you've tried one of these devices. The efficacy of trabeculectomy is not in doubt, but the risk profile associated with it is sort of the thing that puts people off doing it too early. So it's early stage disease. These microinvasive glaucoma devices are useful for, but they're not recommended in advanced or secondary glaucomas where you need a lower IOP and a greater efficacy. So thank you very much for that talk. We're now moving on to Magdi Halal from Cairo in Egypt, who's going to talk to us about ab interno trabecular implants, so further on the same theme.
Good afternoon, dear colleague. First of all, I would like to thank the organizing committee for this nice organization, especially Dr. Mohammed Hisham and Dr. Tamer Yamay. I was asked to talk about the apo-internal glaucoma surgery, and just I'll do a few comments about the talk of Dr. Walid, that the E-Express shunt started at 2001, and when they started it, it was with injector, and you go through the conjunctiva and just inject it. And that was the advantage, that you will go about 8 millimeter from subconjunctivally and inject it. But there was a problem after that. That's why they put it by this way. And till now, I don't know why. Shall I put $500 more to put the device in the eye and do trabeculectomy also? Anyway, we know that the glaucoma management is differ according to the patient condition. If we can see this patient is 79 years old, and this is the right eye and this is the left eye. As you can see, it's advanced eye, and he's on 3 medication and is still uncontrolled. So the management of this eye definitely is different from this eye, especially, as Dr. Reed said, there is many options now are there. The apo-internal glaucoma surgery is the new one, is the trabectome, a Zen implant, and suprachoroidal device. I'll go through quickly through these. It's approved 2004, and it is just cautery ablation of the trabecular meshwork for about 30 to 60 degrees to do a direct communication between the anterior chamber and Schlemm's canal. This is the machine. It's, oops. The machine is a handpiece, irrigation aspiration line, irrigation aspiration units, and high frequency generator, and a foot switch like the one for phaco, 3 steps. And the tip is bended 90 degrees to facilitate its introduction. The handpiece, it's worked by the first step to foot switch step is irrigation, and the second aspiration like the phaco one, and the third one is electrosurgical pulse. Here is the surgery. You will do just paracentesis, and then with the gonioprism, with the help of the gonioprism, here is the probe, handpiece of the machine, and you will go in and insert it anterior to the scleral spur, and then go and then press to ablate. As far as you can reach, and then go slightly out, and then turn the tip of the trabeculum 180 degrees, and then go to the other side, and then ablate it. There are trabeculum since 2004, and there's a lot of studies about this. But if you can, the conclusion from this is that it lowers the intraocular pressure, but as you can see, it doesn't lower it much. It's lower it in about high teens or 20s. And as you can understand from what's happening here, it's working the same like the laser trabeculotomy, the one Dr. Walid said, and just go and make a puncture to get an access between the anterior chamber and the Schlemm's canal. And I think this also at 2002 started, and they were making propaganda about it, but it's vanished now. It's not working because it's after a while it's closed. Did you hear about it, James? The laser trabeculotomy.
Laser one?
Eczema laser.
Eczema laser. Eczema laser. Yeah, I've heard that in much.
I think it started for about a year, and then this is a study done in 2011 comparing the trabeculotome surgery with the trabeculectomy. And after 2 years follow-up, the success rate is 22% in the trabeculotome and 76% in the trabeculectomy study. Hyphema maybe is the only complication with the trabeculotome. Otherwise, the trabeculectomy definitely has more. Additional glaucoma surgery in the apo-internal surgery was more, is 43 compared to 10% in trabeculectomy group. The other device is the Zen implant. It is many invasive approach to the gold standard. I am doing trabeculectomy, but I am doing the E-Express, but from inside, from the apo-internal. This is the Zen implant. It is just, as you can see here, it's very small, 6 millimeter long, and the size of human hair. And the idea, they put it in a preloaded IOL-like injector to be injected in the eye. And as you can see, it's nicely conformed to the ocular tissue, so it doesn't cause the problems with the other synthetic material like the tubes, like migration, erosion, and corneal endothelium problem. This is an OCT picture of the Zen implant. How to do it? Just with the injector, go through the anterior chamber and go out through the subconjunctival space, and then start to inject it, and then leave a piece outside. Okay. Here is the stent, the Zen implant, and the needle is 27 gauge needle. And usually they do it with phaco. After finishing the phaco, you can go with the injector and go in the anterior chamber near the iris to avoid touching the cornea, and then start to go out. There is a mark preoperatively done, just to know 3 millimeters from the limbus, and go out with the needle under the conjunctiva, about plus minus 0.5 millimeters from it. And then when you go out, start to invert the tip of the needle, and this instead of the bearing up now, start to invert it in the other side and inject. I'm waiting for the gonioscopy. Here, a bleb is formed. And with gonioscopy, you can see the, oh, sorry. Here is a bleb of trabeculectomy. And this is the one for the implant. It's very low and is not high, so it's avoiding the problem of the bleb. What is the potential benefit of Zen implant? You are doing the surgery which are used to do. Many invasive to the subconjunctiva, so not the section of the conjunctiva. It's soft and minimize the complication of the synthetic material. And importantly, we are not playing much with the tissue. So we have a space to do other glaucoma surgery. And this is a multi-center study showing that in 9 months, there is a reduction of intraocular pressure. The problem of all these is the long-term follow-up. The suprachoroidal stent, as Dr. Wali said, the idea is to get to bypass. Here it looks like this. This is the inlet which goes inside the eye, and this is shoulder retention arcs, and here is the cutting tip which goes in the trabecular meshwork. Here is the normal passage of the aqueous. If it's blocked, if the trabecular meshwork is blocked, so the aqueous will not go through this. So the implant will bypass the obstruction in the trabecular meshwork. And here, if you can see, there is Cypass micro stent and iStent Supra, which is 2 different companies, but the same idea. I think there is a video. But the video will not go through. The iStents statistically decrease the intraocular pressure again. And if you know, Dr. Walid said something about the Solex gold plate, which is the idea is to put in the anterior chamber and in the suprachoroidal space. But this doesn't work. I don't know how this also will work. It's the same idea. The studies given give intraocular pressure is good, the complication is minimal, and the intraocular pressure in 2 years or 18 months, it's about 10 millimeters. What is the advantage of the suprachoroidal implant? It's extra intraocular pressure control, easy to insert, and non-dependent on the conjunctival tissue. But we don't understand much about the suprachoroidal space. And we cannot manipulate. If we put it, you cannot do anything. Tube migration may occur and scarring and membrane formation. The subconjunctival implant, the Zen implant, which is doing like trabeculectomy, it's easy to insert. Post-operative manipulation, we can use mitomycin, we can do needling. Like the problem is there is still bleb, risk of hypotony, and wound leak. Remember that all these surgeries keep the eye tissues almost non-touched. So you have the chance to do other regular glaucoma surgery, and that's the advantage of this one. Even if it doesn't work, at least it doesn't. You know, the viscocanalostomy and the deep penetrating, you're doing a very big opening, which if it doesn't work, it destroys your conjunctiva. So the same patient which we were discussing before, in this case, definitely the right eye, if he needs cataract surgery, we can do phaco alone, or it's a moderate intraocular pressure control. We can use the phaco plus micro incision glaucoma surgery, and if it's advanced like this eye, we can use trabe or tube. Just I want to remind you that in the hypertension treatment study, there is 4 millimeter reduction in intraocular pressure sustained for at least 30 months. So phaco alone may help. So this microinvasive glaucoma surgery may lead us to the promising land to control intraocular pressure in glaucoma patient, but still I think it needs more work. Thank you.
Thank you very much for that excellent lecture. Again, some key points were highlighted. Patient selection is crucial for these new devices. You can't use these devices and expect them to work well in patients with advanced glaucoma or with very high IOP. So when you're choosing a patient, you need to look at the presenting IOP, the number of medications the patient's using, the extent of optic disc damage, and also the age of the patient, and then choose whether you're going to use a newer device or one of the traditional glaucoma surgeries. Thank you very much. Have you got any questions so far on microinvasive glaucoma surgery before we move on to the diagnosis section of the lectures? Have you got any experience of trabectome or iStent they'd like to share with us? I can't see any hands coming up. Any questions at all? Okay, so is Mohammed Hisham Ali here at all or not? No, so I will do my talk on OCT in glaucoma. So I have the slides for my OCT lecture, please.